All right, guys, so here is going to be your recorded lecture on pancreatic disorders. This is the first time I've done this via voiceover and PowerPoint versus some other methods I've used, so hopefully we don't run into any issues. But if you're recording this and something seems weird, please just reach out to me over the weekend or next week when you have some time to really listen to this. So we're going to cover pancreatic disorders. Mostly what we're going to talk about is acute versus chronic pancreatitis, and then also cancer of the pancreas. So this shouldn't be long, especially since I'm not in class talking to you, and hopefully it won't go on and on and on about things. Little review of anatomy and physiology. Don't forget, we are just talking about liver disorders, and we're going to finish that conversation as well. And here is just another picture of where the liver is, where the pancreas is, how they're kind of all tied together. You can see that liver sits right up underneath the diaphragm. Below that then is the pancreas. The stomach really is over there too, near the head of the pancreas here. And all of this, liver, common bile duct, gallbladder, pancreas, all going to drain into the duodenum. So it has lots, these organs have lots of different functions, but they're all also tie into the GI tract. So again, what are some of the functions of the pancreas? Well, last semester we talked really about the endocrine functions of the pancreas, and those being secretion of insulin and regulation of blood glucose. We also at some point have talked about the exocrine functions of the pancreas, which is where secretion of enzymes to help in digestion of food. So it does both of those things. We are also going to talk then really about what happens when the pancreas gets inflamed or infected. So in diabetes, we talked about what happens when the pancreas doesn't do its job in blood glucose regulation. And now we're really talking just about the organ in and of itself. What happens when it gets angry and inflamed and irritated? So here's some pictures kind of showing what it might look like when somebody has acute versus chronic pancreatitis. So in acute pancreatitis, maybe we have something like this gallstone over on the left stuck in one of the ducts that helps to drain the pancreas, or in the common bile duct, and it kind of backs everything up, including those enzymes that the pancreas secretes to help us digest the nutrients. When the pancreas can't drain or empty properly and all those enzymes are backed up, of course the pancreas is not going to like that. It's going to lead to some self-digestion, autodigestion actually, of pancreatic tissue. So that's not going to work out really well. It's going to get really irritated, inflamed, infected. Of course, it's going to hurt a lot, just like when anything is inflamed or irritated. Versus over here on the right, where we really have a picture of chronic pancreatitis. This happens, the pancreas, for a lot of different reasons we're going to talk about, but this pancreas looks a little different than the red inflamed pancreas, because here the pancreas is really atrophied. We have maybe dilated pancreatic ducts. We might have stones or sludge within the pancreas. In general, it's just not functioning the way that it should, just like really with any chronic illness. So a little more details about acute pancreatitis. We already mentioned this self-digestion of the pancreas by its own proteolytic enzymes. Of course, it's not going to like that. Why does this happen? Well, it can happen from gallstones like we see in this picture down here on the right, or it can happen related to alcohol abuse. And the rationale for that is right there at the bottom of the slide, that alcohol causes hypersecretion of these pancreatic enzymes and has a direct toxic effect on the cells of the pancreas. So in both of these cases, whether it's a stone lodged in the common bile duct causing backup of those secretions, or alcohol abuse, which causes hypersecretion, what's happening is there's too many secretions within the pancreas, and it's really causing self-digestion, irritation, and inflammation of the pancreas. Usually acute pancreatitis is a mild self-limiting disorder, but it can go all the way up to a severe, rapidly fatal disorder that does not respond to treatment. About 200,000 cases annually, 80% of them are from cholelithiasis, which is a stone from the gallbladder in the common bile duct, or this sustained alcohol abuse. When we see mild acute pancreatitis, we have edema of the pancreas, inflammation, and recovery typically in less than 6 months, typically even within a couple of weeks. Some of these patients may require hospitalization because they can't eat. and drink, and they can't keep anything down for hydration and nutrition purposes and pain management. Others can manage it at home, all the way up to the severe acute, where we have widespread enzymatic digestion of the gland, bleeding, thrombosis, abscesses, necrosis. Anytime we start seeing those terms naturally, it's going to be a very severe thing that's occurring. Clinical manifestations, nausea, vomiting, the severe abdominal pain usually happens within a few minutes after eating food, typically are high-fat foods that require bile from the common bile duct. It can range anywhere from mid-epigastric across the back, across the top of the stomach, does not just confine to right upper quadrant. They have sometimes abdominal guarding, which can often mean that they have peritonitis, which is a bigger problem. The sicker they are, the more symptoms they're going to have. So, in the severe end of that acute pancreatitis, they're going to have hypotension, tachycardia. They might even have ecchymosis on their back right flank area, meaning that there's some bleeding that's occurring in there. Of course, those would be severe signs. Typical signs and symptoms, patients present to the ED with like multiple days of nausea, vomiting, and a worsening abdominal pain that they just can't tolerate any longer. How are we going to diagnose it? Amylase and lipase are the enzymes that we're going to look at that show a direct correlation to the pancreas. Of course, we can also look at an ultrasound or CT to back up, but typically a good history with elevated amylase and lipase is going to be diagnostic in and of itself. White blood cell is going to tell us if there's a severe infection. Hemoglobin, hematocrit, if there's some bleeding that might be occurring. Treatment, what are we going to do for these clients? The best thing that we can do is make them NPO. The reasoning behind that is because every time they eat, their pancreas tries to secrete enzymes. So if they're not eating, we're technically resting the pancreas. We need to do this until their pain has subsided. When they start eating again, then we start with clear liquids, slowly introducing foods, bland, kind of low-fat diet, because we don't want to stimulate the pancreas and the gallbladder and all of that too much. They might be NPO for weeks. At that, 7-day mark, if we're even at 5-day mark, if we're thinking, oh, they're going to have to be NPO for another week, then probably we're going to need to consider putting in a PICC line and giving them TPN. They may need an NPO, an NG tube to suction so that their stomach isn't even secreting enzymes that are trying to go down. Some do okay just being NPO, so it really depends. Probably going to need IV pain meds. Typically, we're using Dilaudid. There's some conversation that morphine causes spasming of the sphincter of Oddi, which is a sphincter within the pancreas. So typically, we try to avoid that. IV fluids and blood if they need it. Of course, if they're NPO, we better be giving them IV fluids or they're going to end up dehydrated. Bed rests, they might need a biliary drain if they have a bunch of fluid within their common bile duct. We might need to put something in there to help drain it. So what are some nursing diagnoses? I'm going to give you guys a minute to kind of think, just like if we were in class. I gave you guys a 1-minute care plan sheet, so I think it would really behoove you to spend some time thinking about the nursing care of these patients. Remember, on a question, it's not going to ask you about, can you list out the treatment mechanisms, right? It's going to ask you, what are you going to do for this patient? When can they start eating? What can they start eating? What type of fluids are they going to need? How are they going to feel, right? How can you care for this patient is how your NCLEX and your test questions are going to ask you. So some nursing diagnoses we might consider. Acute pain absolutely is going to be a number one here. Risk for fluid volume deficit related to being NPO with an NG tube possibly, the need for IV fluids, imbalanced nutrition less than body requires. Those are probably going to be your biggest things, but then also things like knowledge deficit. If this is related to alcohol abuse, we need to start having that conversation about stopping drinking, decreasing how much they are drinking, all the way up to ideally just stopping drinking. So a lot of discussion here, especially if this is their first time admitted for it. But even if it's their third time, then maybe it's even more important that we spend time talking about why it's so important that they stop drinking. Chronic pancreatitis, here we're really thinking about the fact that this is a chronic condition. It's characterized by progressive destruction of the pancreas. Cells become replaced with this fibrous tissue with each attack. So every single time they have an attack, we're doing worse and worse to their pancreas. What causes this? Sustained alcohol abuse, right? So here's a trend. Cigarette smoking, also. Some research is indicating even a low protein or a high fat diet, which can be somewhat common in our society, is also responsible for chronic pancreatitis. Often patients have chronic pancreatitis before their first acute attack. So it's not like you see patients come in with an attack, we call it acute pancreatitis, and then on their fourth or fifth attack, we now consider it chronic. It's really about how the pancreas looks and the changes that are occurring within the pancreas that considers it to be either an acute or a chronic pancreatitis. How do these patients feel? Well, they're going to feel pretty much the same. Their pain might not be as severe as their body somewhat kind of adjusts to it, but they're still going to very typically have the nausea, the vomiting, the upper abdominal pain, or the back pain, and this is going to keep coming. Eventually, as well, they might develop weight loss related to diet and eventually malabsorption. Remember, the pancreas is responsible for helping us to break down and digest carbohydrates, fats, and proteins. So if it's not working and secreting the thing, excuse me, it needs to secrete, then that's going to be a problem. And when that starts to happen, or when that's really happening very, very detailed, we start to get this steatorrhea, which is this frothy, foul-smelling stools. So in the liver, we talked about how they have clay-colored stools, and here for pancreas, we see these really frothy, foul-smelling stools, and it's related to their inability to digest fats. Pain management is going to be a big thing for them because we're going to be managing their pain on a long-term basis. They might have pain all the time, or they during these attacks. What are we going to do for it? So avoidance of alcohol and diet regulation to prevent future attacks, prevent continued breakdown of the pancreas is going to be the best thing we can do. If it's a gallbladder issue or a common bile duct issue, then we need to get in there and do some surgical operation to take the gallbladder and the stones that are in it out. Is there stenosis or some sort of impairment in the common bile duct that we need to replace? What we can do is this ERCP, endoscopic retrograde cholangiopancreatogram, which basically goes in, a scope that goes in, and we can actually look up through the common bile duct and see if there's issues. We can actually take samples of the pancreas and see what's going on with the actual pancreatic tissue. It's going to be the thing that probably tells us the most that they actually have chronic pancreatitis versus an acute pancreatitis. This pancreolipase is not on your farm objectives. It's not that big of a deal. What you need to know about it specifically is that it's an enzyme used to help with nutrient absorption. So it's basically like replacing the enzymes that the pancreas should have been secreting, but now isn't. We give it for chronic pancreatitis patients. We also give it for CF patients because they struggle to secrete pancreatic enzymes as well. Cancer of the pancreas is really our next topic here, and we're really just moving right through this because we were going to do some 1-minute papers and some 1-minute care plans, which I'm hoping we can do a little bit of on Tuesday. So cancer of the pancreas, 4th leading cause of cancer death in the US. 70% of cancers affect the head of the pancreas. So it's showing you there in that picture a tumor in the head of the pancreas. 80% are not diagnosed until advanced and unresectable, meaning that they're so advanced we can't take them out. So hence why that's a really big leading cause of cancer death in the United States. If they're so bad by the time we recognize them that we can't resect them, there's really no cure for it. Why does that happen? Well, because the pancreas is kind of tucked back behind, it's not obvious that there's a mass growing there, and the pancreas is still doing its job, so we don't see signs and symptoms that are going to lead us to believe that they have any issue with their pancreas. Typically greater than 45 years of age, cigarette smoking, high-fat diet, chronic pancreatitis. kind of seeing a theme here amongst these patients with some similarities. Diabetic patients, we also see an increased risk of pancreatic cancer. And then the pancreas is also a very common site for metastases from other parts, other cancers throughout the body. How do these patients feel? Pain, weight loss. Weight loss, typical for any type of cancer. Pain, it kind of just is like vague upper to mid-abdominal discomfort, then starts to get worse. They might start to develop some ascites, some jaundice, as we can impact the common bile duct. We can alter drainage from the common bile duct, so therefore we get liver being affected as well. Insulin deficiency, as the pancreas doesn't work and the tumor begins to become enlarged and really encompass a great majority of that pancreatic tissue, then of course it can't also do its job related to regulation of blood glucose. Diagnostics, a spiral CT, an MRI, or an ERCP are going to be our best ways to diagnose. We need to get a biopsy of it to see. Even sometimes we don't, we can do a CT or this MRI and see it, see the mass in and of itself, see the metastases, and make determinations. Often our management is palliative care. Whether that involves radiation and chemotherapy, it really depends on the patient and what their goal is. But if 80% of them are unresectable by the time we diagnose, then really we're just trying to elongate life with good quality of life. And so that's really, really patient specific. The surgical procedure that we can do to remove part of the pancreas is the pancreatic duodenectomy, which is also known as the Whipple's procedure. And so here's a picture. There's another picture in your book, your med-surg book, that looks similar, a little bit different. Basically what we do is we remove the portion of the pancreas where the tumor is located. We then connect the pancreas directly to the duodenum. We also take the stomach and resect part of the stomach and empty that into the small intestines as well. So we somewhat are rerouting things, but things can still do their job. So we still have the common bile duct over here on the right draining into the small intestines. We still have the stomach going into the small intestines. We still have the pancreas going into the small intestines. So we still have the things that we need to have there, and we get the patient preserving function, basically. This is the best case scenario for patients. They can live long, fruitful lives after this type of procedure. Care of them is going to be pretty detailed, though. They are going to have multiple drains after this type of procedure. So we see that big abdominal incision there. They might have irrigation going into the belly and coming out. They're going to have certainly maybe some sort of PEG tube or jejunostomy tube for feedings, and that nasogastric tube sucking everything out of their stomach so that they don't have enzymes and such sitting in the stomach after we just surgically incised it and cut it and did all of those things. So this is going to involve a lot of care. The GI tract took a hit, the endocrine system took a hit, the liver and the gallbladder, and that drainage system was altered. So lots of things to think about in the postoperative care of these patients.